The next speaker is Dr. Scott Plotkin. He's a neuro-oncologist and the director of the neurofibromatosis clinic at Massachusetts General Hospital. He's also the director of the hospital's neuro-oncology fellow program. He's the founder and the chair of the RANGE International Collaboration, and he's leading studies in NF2. Thank you, Scott.
Great. Well, so glad to be here. Thank you very much for having me. And very happy to speak about NF2 today, a topic which is, of course, very important in our community, but given the numbers of patients, sometimes we don't hear as much about it. So I'm happy to be representing NF2 researchers and investigators along the way. By way of disclosures, as we always do, just to let you know that there are no FDA-approved drugs for treatment of NF2. And just by way of introduction to make sure we're all on the same page, just a couple of comments about NF2 itself. It's less common than NF1, about 1/10 as common, with about 12,000 Americans affected. We know that the reason people have the NF2 condition is because of genetic alterations in the NF2 gene. We have fairly good diagnostic criteria, which include mostly looking on brain MRI scans for vestibular schwannomas, which are benign tumors that affect the vestibular nerves or the hearing nerves, and there are other manifestations that can contribute to the diagnosis of NF2. Patients with NF2 are typically diagnosed later than patients with NF1, often symptoms appearing in the teenage years, but diagnosis being delayed into the third decade, usually around the early 20s, but sometimes later, as we heard about this morning. And like NF1, patients with NF2 have multiple tumors typically and multiple tumor types, and I've tried to show you a few of those on the right there. The top left MRI scan shows you bilateral vestibular schwannomas, the hearing tumors with the arrows. To the right of that is a meningioma, which is a tumor of the covering of the brain, which is, I probably should change the picture because it doesn't look like there should be a covering of the brain on the inside, but you can see meningiomas there. The bottom left MRI is a spinal ependymoma, which occurs at the junction between the brain and the spinal cord in this case. And the bottom right MRI scan shows multiple spine schwannomas, which, like NF1, in which these tumors can develop, you can get myelopathy or weakness or spinal cord compression. And like NF1, although these tumors are histologically benign, meaning if you go to a pathologist and have them look at it under a microscope, it's not cancerous, the effect of these tumors on patients is, of course, very significant. So I throw this up here on behalf of my colleagues who are in the lab to show you that the signaling, the intracellular signaling, is incredibly complex in NF2. And one of the things in our community, the NF2 community, that we're jealous about NF1 is we don't understand NF2 pathway as well as we understand the NF1 pathway. There are many reasons for that, certainly not for a lack of effort, but the fact remains that unlike the classic cancer biology that has informed NF1, we don't have that in NF2. And in some ways, this is a completely novel mechanism that we have spent many, many years examining. Having said that, you can appreciate the challenge when you look at a slide like this. Where do you target? Where do you go? And I think that's been one of our challenges. We do have lots of drugs, and you can't see it here, but it's all the red text. We do have drugs to affect parts of the pathway. We just don't yet know what the most important area to target. Now, as a clinician who sits with patients, this is what I think about when I think about clinical trials for NF2. The first is what tumor is being treated. Is it a vestibular schwannoma? Is it a meningioma or an ependymoma? And then the other question to ask yourself is, what is the primary goal of the clinical trial? Is it to shrink a tumor, or is it to improve hearing, or is it something else? So here are some of the trials that have been completed, and in this case, these were trials that were specifically designed to shrink vestibular schwannomas. There's a drug called lapatinib. This was run out of NYU Langone Center with Matthias Karianis as the PI. It's a drug that's already approved for treatment of breast cancer, and so we know a lot about it. In this trial, they enrolled 17 patients, including both children and adults. And I want to make just an editorial comment that the community has been really good about pushing drug companies to include children in our trials. That is incredibly challenging, and the drug companies don't like that very much because they worry a lot about side effects, but we are continuing to push to include children. In this study of 17 patients, only one patient, 6%, had tumor shrinkage. 31% of individuals had some improvement in hearing. But I think the challenge with this drug was that these improvements in hearing were very short term. That is, they stopped after a few months. And so our impression as a community after the study was there was some interest in going further with these studies, but since these tumor responses were short duration, we haven't come back to this drug to study in more detail, at least not as monotherapy by itself. A second study that's been completed is a drug of everolimus, I think also called Afinitor, if you know that name. This is a drug that is approved for tuberous sclerosis complex as well as other types of cancer, kidney cancer, breast cancer. This trial also included children and patients. They had 10 patients. Unfortunately, the results weren't as good as we had hoped. We saw 0% of individuals with tumor shrinkage and 0% with hearing response. But they did identify 5 patients who had prolonged stable disease, meaning that the tumor didn't grow for an extended period of time or hearing didn't drop for an extended period of time. And so it shows you the complexity of clinical trials. On one hand, we didn't shrink things, that's what we were looking for, but we saw a signal that maybe the tumors wouldn't grow in some patients. And so this is informing our decision about new trials where maybe this is a drug to prevent tumor growth that we can try earlier in the pipeline rather than a drug later on when we need tumor shrinkage. So like with anything, sometimes your failures turns into new ideas that you can explore in another setting. Whoops. And I just want to mention on the bottom there that we still are awaiting additional trial publications. Some people in this room may have been treated with AR-42 or axitinib, and there have been some individuals treated with rapamycin. And unfortunately, I don't have those reports for you today, but we hope to have those come out in a little bit. There's also been clinical trials to improve hearing related to vestibular schwannomas, and those have been primarily the trials of bevacizumab, which is an anti-angiogenesis drug, which means it works on the blood vessels, not on the tumor, because we know that how the brain supports these tumors is another way to affect their growth. In this study, which included children and adults, there were 14 patients, and I highlighted and read the dose here because the next study I'm going to show you has a different dose. So in our initial study at 5 milligrams per kilogram, actually it was 7.5 every 3 weeks, but it'll make an easier comparison. At this dose, we saw tumor shrinkage in about 43% of individuals and hearing improvement in 57%. Now, to me, these are spectacular results, and while we certainly wish that these were 100% improvement in hearing, the fact that we can improve hearing when there are no other therapies that can do that, neither surgery or radiation, really opens the door for improving quality of life and function in a way that we've never had before. One thing that was important about this clinical trial is that it was designed by J. Shree Blakely, Johns Hopkins, Brigitte Wiedemann, and I, was that this study required people to be treated for 12 months and then it mandated a stop. Now, in some ways that seems like not a nice thing to do, because if you're doing well and you have to stop. On the other hand, it provided critical information. Absolutely critical, and that is what happens when you stop a medicine, because most people can't be treated for their entire life on a drug safely. And what it taught us was that the drug, because it gets metabolized by the body very slowly, lasts a long time, and people don't lose hearing rapidly. There's no rebound effect, which means that you can be treated with the medicine, you can come off for 3 or more months, and then restart again. And that's important because sometimes people need to have a tooth pulled, or need to have a surgery, or they just don't want to be on treatment for a period of time. So we learned an incredible amount from that study. In the follow-up study, we looked at bevacizumab again with a different question. The question was, hey, if it works at 5 milligrams per kilogram every 2 weeks, what about more? You know, this is America, more is better. So we gave 10, which is the standard cancer dose, right? So it was a safe dose. We treated 22 patients, and what I'm not happy about is the fact that we did not improve our outcomes. Tumor shrinkage in about 38% of people and hearing improvement in 50%. So again, maybe not the result I had hoped for, but on the other hand, very important. Now we know we don't have to treat people super aggressively, and because these drugs are hard to take. And it gives us more of an understanding of the best way to treat patients with this drug, which can improve hearing. Really having problems with this thing. Okay. So ongoing and future trials for vestibular schwannoma. For the studies I'm going to tell you about now, the primary goal is either to shrink the tumors or to keep them stable in size. So one study that's ongoing is a drug you've heard a lot about today, selumetinib, which is a MEK inhibitor. Our community is exploring the activity of this drug in the setting of NF2. That's at Cincinnati, and no results are available yet, but we hope that accrual is going well. There's a second study of aspirin that's the PI is Tina Stankovic at Mass Eye and Ear Infirmary, and Dr. Brad Welling, who's our speaker today, also is deeply involved in this study. This will be a placebo-controlled trial, meaning some people will get aspirin and some people won't, but everybody ultimately will get aspirin with the idea that this drug should be a safe way, if it works, to prevent tumor growth. And so that trial will be opening very soon. There's another trial that's opening soon of crizotinib, which is a MET-FAK inhibitor, and that's being run out of the Department of Defense Consortium, which you see on the right. We hope that'll open in 2019, so if people are interested in that trial, please look up the DoD website, and you can find where the different hospitals are that are accruing patients. So there are not many trials that were designed specifically for meningioma. This is the only one of which I'm aware. This is a study at our institution of a drug called AZD2014. That means AstraZeneca drug. It's a drug related to everolimus, the drug I told you about before. It's a next generation everolimus. So the last one has 0% tumor shrinkage, 0% hearing improvement. We're looking at this new and improved drug in 18 patients. I can say it's been very gratifying that we enrolled 18 patients in less than a year, which nobody thought we could do it, and it shows you how interested individuals are to participate in research and to learn more about it. We're just shy of having our results. If this conference was a few months later, I could tell you, but we're anxious to get that information out soon to everybody. And then, unfortunately, we have never had a trial for ependymoma, spinal ependymomas. I get calls all the time about this. And I would say that we in the community are very interested in having options for patients for ependymoma, and we're working very hard to develop a trial, hopefully within the next year, for this tumor type. So where are we going? What about future trials? In my own opinion, this area is really being powered by Synodos for NF2, which you've heard a little bit about. This is the large effort funded by the Children's Tumor Foundation to bring together many of the large research labs that work in NF2. So for disclosure, of course, our group was involved in this, and I think it was a tremendous success. The hardest thing to do is to get all the groups to talk to each other, and I could tell you over a beer one day why that is. It's not because people aren't nice, it's just an incredibly complex thing to do. And Children's Tumor Foundation really has paved the way to make that work for us. I put up this slide to show you the complexity of pulling together 5 to 10 research labs across the country. But what I can tell you now that we've finished this project in terms of the experimental work, we have multiple new targets that I think are very interesting for clinical trials. And we've already submitted our concept design to a drug study, which I'm very hopeful will get approved. So we could see some results from this very soon, I think, from the Synodos effort. I thought I had one more slide.